The next speaker will be Josephine Vos, and her title is Disease Morbidities, Renal, IgM-related and Hyperviscosity.
Yeah, that's exactly my title that I received from the organization, and I definitely want to thank the organization for inviting me to give this talk. IgM-related disorders, renal function, hyperviscosity and cryoglobulins are 4 subjects, so I'm going to try and stay within the time a little bit. En ik zou graag jullie zeggen dat ik heel moet zeggen, trots ben dat er zoveel Nederlandse patiënten zijn gekomen. Ik had geen idee eigenlijk dat het zo enorm leefde dat iedereen hier zelfs op zijn vrije zondag vandaag bij wil zijn. Dus dat is een extra grote eer. Can I have my next slide? Oh, I can do it here. Oh, sorry. I have no disclosures. I just want to say we had a really amazing we had a really amazing conference the last couple of days. I know some people have been here for the last days, but it was extremely inspiring, and to have a conference like this in your hometown is a very big honor as well. So I want to start, don't pay attention to the details. This is the Dutch medicine a couple of 100 years ago. This is a very famous painting by a very famous painter, Rembrandt van Rijn. He actually painted this anatomy lesson as it was given. We do it a bit modern now in Holland, but at the time this was what we had. And this painting was made actually in Amsterdam in a building that was the anatomy theater, and it is still there on the New Markt. And the doctor that is demonstrating, the professor, so to say, is Dr. Tulp, which means tulip in Dutch, so in many ways this is a very Dutch painting. Just couldn't resist to show it. I will talk a little bit about complications of Waldenström's disease, and a couple of them are rare, a couple of them are more frequent. IgM-related disorders, when there are not many tumor cells, but the IgM itself can still be tricky. Hyperviscosity, when the blood becomes too sticky, and I realize now it rhymes, but it wasn't meant that way. Cryos is when cryoglobulins, which makes the blood clot in cold circumstances. And finally, renal disease related to Waldenström. As some of you may know, I had the chance to work at the Bing Center in Boston for half a year last year, and one of the 2 projects I did was on kidney complications in Waldenström's disease, so it's a subject that I have a lot of enthusiasm about. So IgM-related disease is when, so Waldenström's disease is when someone has a high tumor load in the bone marrow, high IgM levels, and symptoms arising because of that. So typical symptoms would be anemia, for example, or hyperviscosity. On the other end of the spectrum, we have IgM-related diseases where there is very low tumor load, or sometimes even no tumor cells identifiable, but still people can get into a lot of problems, and this is termed a small dangerous clone. Dr. Garcia-Sanz also mentioned this distinction earlier on. There are a lot of types of IgM-related diseases, and this list may not be exhaustive, but the most famous ones are the deposition diseases, for which amyloidosis that we just heard about is the biggest group, but also light chain deposition or deposition of the IgM globulin itself can cause problems in the body. Then there is neuropathy, which Dr. Minema just told us all about. That's the most frequent one, I would say, out of this group. Then there is the kidney disease, which I will tell more about in a little while. Cryoglobulins, which we'll hear about. Cold agglutinins, which lead to attack of the red blood cells by the IgM, leading to anemia. And there is a very rare skin syndrome called Schnitzler disease. So there are lots of types of IgM-related diseases, and they all have their own clinical phenotype. So how should we treat these is a question we cannot answer as a group, because it really depends on what type of IgM-related disorder you relate to, and most of them will be discussed separately today. Hyperviscosity, so this is a very famous complication of Waldenström's disease, and probably the most dangerous one, I would say. Viscosity is a concept from chemistry, and it has to do about how easily a fluid will flow, and the typical way to explain it is to compare water to honey. If you pour water from a cup, it'll just fall out. If you take honey, depending on how old it is, it will drop very slowly, and it's very sticky and viscous, and so honey has a high viscosity. So to understand why this is linked with Waldenström's, Waldenström's macroglobulinemia. Macroglobulin means a very big globulin protein, and here you can see that the IgM pentamer is actually so much bigger than the IgG, which we see in myeloma patients. So Waldenström's patients have a much higher risk of getting the very thick blood because of the size of their protein. So hyperviscosity syndrome is also very famous because it was present in the first 2 patients that Dr. Waldenström described initially in 1944. So it means high IgM, which makes the blood too sticky or too thick, or what you want to call it. It happens mostly at very high IgM levels. So in America, I think it would be above 6, if I remember correctly. In Holland, we would say above 60, depending on your metric system. But it can also already happen at 3 or 30 grams per liter. The symptoms that it can give are bleeding, mostly nosebleeds. Retinopathy, the retina is the back part of the eye where the light impulses get in. So that very important part of the body. And in the end, neurological problems that, if left untreated, can become very severe. So this is the way to diagnose hyperviscosity syndrome, is to do a special eye exam where you look at the retina and you see that the blood vessels, which you can see, right over here. So these are the blood vessels that bring blood to the eye, basically. And what you can see here is that they have these, well, so in America they call this hot dogs on a string type appearance. We don't do hot dogs on a string in Holland, so I wasn't sure how to translate it, but it means you have all these little sausages stuck together. So you can see that over here, and it means that these little, tiny vessels that are very important for the eye to function are in a lot of trouble when you see this. And when you see this for a hematologist, it is an emergency symptom. So how to diagnose hyperviscosity syndrome? Probably look at the paraprotein, of course. You can do a viscosity test in the blood, but it's not very reliable always. So most important is for the doctor to be aware of the symptoms and to do the eye exam when you have a suspicion. How do we treat it? So plasmapheresis is a sort of dialysis technique where you can filter the blood on a machine, and that is a way where you can filter out the IgM and bring the viscosity down. Of course, it works only temporarily because the body will keep producing the IgM and it will come back up again. So you have to do the plasmapheresis sessions to keep the IgM low enough while you have introduced a rapid-acting treatment, chemotherapy or some novel therapy to really bring the IgM down in that patient. There were no new insights on hyperviscosity itself during the conference, but of course the good news in Waldenström is that we have so many new active agents that are also able to bring the IgM down very rapidly. So in that perspective, we do have better options now, I think. So my next subject is cryoglobulins, another sort of chemistry concept. Cryoglobulins are proteins that precipitate when it's cold. And there are 3 different types that can be distinguished. It goes a bit far to explain it all, but especially type 1, but possibly some of the others too are associated with Waldenström's disease. In type 1, actually the protein that precipitates is the IgM itself. Can also be associated with other diseases, autoimmune disease or hepatitis C. So I had to make this a little bit more alive. So one of my favorite movies is Finding Nemo, and this is one of my favorite characters. This is the fish that when he frightens or something unexpected happens, he blows up. But the good thing is when he relaxes again and realizes nothing is wrong, he can also go back to his normal size again. And it's a bit the same with cryoglobulins. So this is what serum looks like at normal circumstances. Then in a cryoglobulin patient, if it cools down, the protein starts to precipitate and collects in the bottom of the tube. But if you warm it up again, then it will again dissolve and become normal. So Dr. Marvin Stone, I have to tell you his anecdote about his colleague who discovered this phenomenon, because he put a tube in that he wanted to examine later on. He put it away in the fridge, and he came to the fridge and he said, "What's going on in this tube? I have all this protein in the bottom." And he wanted to show it to his colleague, so he put it in his jacket. And once he arrived at his colleague's office, it was already dissolved again, and his colleague said, "There's nothing wrong, it looks normal to me." So this is how they found out that it can actually go both ways. So the symptoms of cryoglobulin, actually a lot of Waldenström patients have a little bit of cryoglobulin, and most of them have very subtle symptoms or none at all. But what you can get are the purpura, so the reddish spots, especially on the legs or other part of the body that are at the end of the circulation, so the ear, the nose tips, your fingertips. But in some patients this can be more severe, and it can lead to very poor wound healing because the skin doesn't get enough oxygen. I think this is what you will very typically see. You know, this will probably not even be bothersome, it's just, it looks weird, but it doesn't have to be painful or anything. Of course, when you do get the ulcers, it can become problematic. So another thing to remind is that if you have the IgM precipitating, like in this thing, and you're going to measure your IgM in the serum, the IgM is going to be 0 because everything is in the bottom of the tube. So in patients with very strong cryoglobulin, you have to measure their IgM levels in a warm situation, otherwise you will never find it. And Dr. Kimby told us, because I once had a patient with very strong cryoglobulins that we wanted to do pheresis, but we didn't, because we were afraid that if once we would get her blood out of the body to put it in the machine, it would just all clot. And she told us that at the Karolinska Institute in Sweden, they have a warm room where they treat the cryoglobulin patients. And we were wondering, maybe the personnel there gets dressed in their bathing suits or something, because, you know, I thought that was one of the amazing things of these conferences, that you find out these little details, how things get done, you know, all around the world. So this I explained a little bit, and some of the rarer complications of cryoglobulins can also have to do with the kidneys and some arthritis complaints and neuropathy as well. What can you do about them? Well, for most cases, it's enough to just try and keep warm and take care of your skin and take care of your wounds. Sometimes when it's more severe, the underlying disease, so in this case the Waldenström, needs to be treated. So apart from that, there is a warm room in the Karolinska Institute. We didn't have any new insights on cryoglobulins during this meeting. Last subject is the nephropathy, so kidney complications related to Waldenström's. I want to show you another picture from the same period of time. This is the last one, I promise. This is a picture by Gerard Douw, and this is also a physician, and he's actually looking at urine. So I said at the conference where I had a talk on this subject, you know, I stand in a long line of Dutch doctors that are interested in urine, apparently. But I think it's a very nice picture because, you know, what can you do when you're in the 17th century? You don't have so many laboratory tests yet, so you just have to look at things. So a brief introduction to kidney. Kidney is the organ that filters the blood, 1 liter per minute, so a lot of blood goes through that small organ every day. And therefore it actually can, in a lot of diseases, the kidney will become involved because the blood goes through it and it's like a sieve. So what we found out at the Bing Center project that I mentioned is that up to 5% of Waldenström patients can develop kidney complications when you wait for 15 years, so after a long follow-up. There is a very great variety in the type of kidney disease associated with Waldenström. It's also important to realize that kidney disease, especially in an elderly person, is also very likely not to be related to the Waldenström. It can be due to hypertension or diabetes, so it is not necessarily said that these things are the same cause. And sometimes a biopsy of the kidney will be necessary to determine which of the two is going on. Symptoms of renal problems are actually very aspecific. People with renal failure don't usually feel a lot unless it gets very bad, and then they start feeling tired. Nephrotic syndrome, when the kidneys leak a lot of protein, that's when people start to swell up and get a lot of edema, also in the face, so that will be something that you can notice yourself. And there is a very rare type of kidney complication where you can get problems in the salt distribution within the body, also something that will usually be picked up by laboratory tests. Although it gets very severe, you can get muscle cramps. So this is what we found out about the types of kidney diseases, and I won't go through all of them, but the most important message is that the biggest groups related to Waldenström's are amyloidosis that we already heard about, and deposition of IgM and IgM tumor cells in the kidney itself. But more interesting, there is a long list of rarer causes that all occur in relationship to Waldenström microglobulinemia. What else do we know? Well, half of these patients get diagnosed together with their Waldenström at the same time, and the rest will have it during the follow-up. They tend to have somewhat poorer outcomes, but if the renal function is saved or even gets better after treatment, then the outcomes are better again. And it's very important for the doctor, the hematologist, to cooperate. And like when you have the neuropathy, you need to cooperate with the neurologist. When you have kidney problems, the hematologist needs to work with the nephrologist to figure out how to proceed. And the treatment of these diseases is very dependent, again, on the type of kidney pathology, which is another reason why a biopsy can be very important. So I just want to show you this picture. This is a case of deposition of IgM in the kidney. What you see here is the sieve, that is the kidney. It's hard to look at, but all these dark spots, usually where the blood flows through and where it gets filtered. And you can see that it's all filled up with these large blobs of stuff. And what this stuff is, if you do a special stain for IgM, you can see that the whole filter is filled up with IgM. So you can imagine that this kidney cannot function very well anymore. And this is one of the variants called IgM deposition disease. What can you do about it? Well, I think it's very important people are aware that kidney function should be monitored, but it's usually part of the standard lab panel, so you should not to worry about that too much, I think. Urine can be checked for protein if there is any doubt. Be aware of symptoms of nephrotic syndrome in Waldenström patients. And for doctors to be aware that this can actually be a complication of Waldenström's, because we know that 40% of myeloma patients get kidney problems, but in Waldenström's it's not that well known, so that was one thing we learned. And what was new, well, we had a discussion about that project based on the Bing Center cohort, where we found all the different kidney diseases during this conference. So that was all. I hope you enjoyed it, and if not, then you can still enjoy the paintings that I showed you, because they're still on show. And thanks again for your attention.
Because we are so efficient, we are running ahead now. So if there are some urgent questions for Josephine or myself, please feel free to come to the microphone, and we can discuss them now.
Small question. You told something about Nederlands.
Yeah. 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 So the question is that I said something about your tongue and in relation to amyloidosis. Well, so amyloidosis is a protein disease when the protein is, I don't know the English word, stapeld, opstapelen. Deposited in an organ, so it will enlarge. So a very big tongue, an enlarged tongue can be a sign of amyloidosis in a patient. That's, dus, zal ik nog Nederlands zeggen? Oké. Oké.
Yeah, so the question is why to check hepatitis C in cryoglobulins. Technically speaking, it's especially type 2 and type 3 cryoglobulins that are associated with hepatitis C, and they will not, to say bluntly, it's always a good idea to know if someone has hepatitis C or no, but also the cryoglobulin will not go away unless you treat the underlying problem. And these days there are very good drugs for hepatitis C, so I would definitely recommend testing it. And another reason would be that one of the other treatments we would give for Waldenström or for cryoglobulinemia is rituximab. And if you don't know someone has hep C and then you give them rituximab, it can give an enormous flare of the virus. So for those two reasons, I would always test it in people with cryoglobulins.
There's one question over there.
How would you go about the cramp symptoms that can be very strong? Sometimes you analyze that one of the side effects could be cramps.
Cramps. So how would you
Muscle
go
cr-
about
yeah.
with cramps?
Yes, when Dr. First said about the cramps, that is one of the side effects that you could see very strongly.
In neuropathy?
Yes, just before she mentioned.
Yes.
How would you go about this? Is there something, is it just potassium, magnesium, water?
But I think the last speaker will go into that in more detail. But I can tell you, so when it's induced by chemotherapy, it's a sign to reduce or stop your chemotherapy if the cramps are there. If they have different causes, then you have to be symptomatic. And some patients find relief in additional magnesium, but also many patients do not, because magnesium is very difficult to be. If you give it IV, it's in your body, but when you take it orally, it mostly works as a laxant. So that's why it's low magnesium is not always the cause, because it's a nerve problem and not a magnesium problem. So it's a very difficult thing to treat. Warm water, that's all fine, but there's no real medicine for that. No. And the painkillers we use don't always have an effect on the cramps patients feel. No, sometimes. So they can be tried too. Okay, then I would like to introduce our next speaker. This is